Let me introduce our esteemed guest, our keynote speaker, Professor Dr. Nasrin Sultana Chaudhary, Head of the Department of Community Medicine, Bosundhara Medical College. And we are very honored to have Professor Dr. Tariq Mahmood Sir, Professor of Medicine at Bosundhara Medical College, as our chief guest. Without doing any delay, I am requesting our today's presenter, Professor Dr. Nasrin Sultana Chaudhary, to her presentation.
To my respected faculties, senior and junior, honorable principal sir, and my dear student, good morning. At first, I would like, and also we have honorable guest here, Dr. Shakil Ahmed, external in our institution, in anatomy department. At first, I show my gratitude to Honorable Principal Sir to give me the opportunity to conduct today's session. Today, I am going to present human metapneumovirus, which is considering a topic in our health in every individual. Now, introduction. The most common illness experienced by people of all ages worldwide is an acute respiratory tract infection. It is a leading cause of mortality and morbidity worldwide. Viruses are responsible for a large proportion of respiratory tract infection. A panic-like situation emerged on social media across China, India, Bangladesh as reported human metapneumovirus. In late 2024, China experienced significant increase in HMPV infection, particularly among children under 14. This surge led overcrowded hospitals and raised public concern, reminiscent of the early days of the COVID-19 pandemic. However, the health authorities have indicated that this rise aligns with typical seasonal pattern of respiratory illness. Human metapneumovirus was first identified in the Netherlands in 2001, but serological study of antibody against HMPV indicate that the virus is not new and circulated human for at least 50 years. Most people will have some pre-existing immunity to it. It is found around the world. Now, what is HMPV, human metapneumovirus? Human metapneumovirus is a respiratory virus that primarily causes infection in the lungs and respiratory tract in the people of all ages, which also include respiratory syncytial virus and parainfluenza viruses. HMPV is classified as the first human member of the metapneumovirus genus in the Pneumovirinae subfamily within the Baraxomiviridin family. It is an involved negative sense single-strand RNA virus. Now, the epidemiology, we see the global scenario. Human metapneumovirus is distributed worldwide, has a seasonal distribution comparable to that of influenza viruses and respiratory syncytial viruses. It tends to strike in the late winter and early spring. In young children, human metapneumovirus is the second most common cause of lower respiratory tract after respiratory syncytial virus, with children less than 1 year of age showing the highest risk of infection, seroprevalence at the age of 5 almost 100%. Walsh et al. Found that the proportion of human metapneumovirus infection in adults varied between 3% to 7.1% in 4 consecutive winters. This is similar to the annual average infection rate for respiratory syncytial virus 5.5% and greater than that of influenza A 2.4% in the same cohort during the same time frame. Human metapneumovirus was identified in 2.2% of patients who visited in general practitioner because of community-acquired acute respiratory tract infection, who were negative for respiratory syncytial virus and influenza virus. HMPV infection is associated with hospitalization for acute respiratory tract infection in adults in the study of Walsh et al. The incidence of human metapneumovirus infection in the hospitalized adult varied from year to year, ranging from 4.3% to 13.2%. This is in accordance with rate of RSV and influenza A. Average annual infection rate for RSV and influenza A were 9.6% and 10.5% in the same cohorts. Whitmer et al. Found that human metapneumovirus accounted for 4.5% of hospitalization for acute respiratory tract infection in adults older than 50 years during the winter season in 3 consecutive years. Rate for RSV and influenza were 6.1% and 6.5% respectively. Now come to the Asia scenario. China, Malaysia, Hong Kong, India reported recently HMPV in late 2024. China reported pretty high in cases. Overwhelming hospital, China did not release any data respiratory infection common in winter. Mild outbreak, they said. India, 3 cases confirmed, 2 Bengaluru and 1 Allahabad. There is no history of traveling but disease found. Now come to the Bangladesh scenario. 12th January, 1 case was found admitted in IDH. There was no history of traveling to outside the country and she died 15th January. Now, what are the clinical manifestations of HMPV? In general, HMPV infection cannot be distinguished from other respiratory viruses on clinical ground only. The symptoms are similar to cold or flu-like symptoms like cough, fever, nasal congestion, sore throat. Runny or stuffy nose, shortness of breath, body ache, headache, and conjunctivitis and otitis media are reported symptoms. Here I am showing a picture, the symptoms of human metapneumovirus. Now, it can make a few people quite sick, causing infection of the lungs, pneumonia or inflammation of the airway to the lungs, bronchiolitis, bronchitis. Symptoms of more severe disease include wheezing, difficulty breathing, chest pain, dizziness, severe fatigue, dehydration, or persistent fever that does not improve. If someone is experiencing any of these severe symptoms, they should seek medical advice. Now, how to transmit HMPV? HMPV infection range from mild to severe depending on the person's age, immunostatus, and underlying health. HMPV is highly contagious and spread through direct or close personal contact with contaminated secretion, droplet infection, or respiratory droplet infection from cough and sneeze, fomites, contaminated surface or object. This is the picture, the mode of transmission I am showing. HMPV is found in excretion of 5 days to 2 weeks after initiation of symptom. Incubation period 3 to 6 days. Symptom lasts for 2 to 7 days. Now, how to diagnosis? A reverse transcriptase polymerase chain reaction RT-PCR test is the most reliable way to diagnose HMPV with a few hours. HMPV is confirmed usually by doing a nucleic acid amplification test NAT. Direct detection of viral antigen in respiratory secretion using immunofluorescence and enzyme immunoassay. Now, how to treat? To date, treatment of HMPV infection is mainly suppurative. HMPV is cold virus. People can treat their symptom with over-the-counter medicine to treat pain, fever, stuffy nose, and cough. Getting plenty of rest and stay hydrated also help. In a small number cases, when people need to hospitalization, doctor may give them extra care oxygen to help them recover. Most people can manage their symptom at home until they feel better. Now, how we prevent? Wear masks, crowded or poorly ventilated spaces, improve ventilation, open windows to improve airflow. Wash your hand often with soap and wash for at least 20 seconds. May use alcohol-based hand rub. Avoid touching our faces, eyes, nose or mouth without washing out your hands. Stay home to avoid infection if you have mild symptoms. Seek medical care as soon as possible you have severe symptoms or are at high risk. Eating a balanced diet, sleep properly, do exercise regularly. If you have cold-like symptoms, you should cover your mouth, nose when coughing and sneezing. I show the cough sneezing etiquette. Wash your hands frequently. Avoid sharing cup and eating utensils with others. Now come to the vaccination. Several animal studies have been performed. Investigation the development of an HMPV vaccine. However, no human study have been performed yet and no vaccine is available up to till now. Who are the risk group? Infant, young children under 5 years old, older adult over 65 and people with breathing problem, asthma, COPD, immunocompromised individuals. Standard precautions are hand hygiene, use personal protective equipment like gloves, masks, eyewear, respiratory hygiene or maintain cough etiquette, environmental cleaning. Here is I'm showing some complication of HMPV, that is bronchiolitis, tiny area of the lungs, bronchitis, inflammation of the bronchus, pneumonia, asthma or COPD, ear infection, otitis media. Now let's have some discussion. Reported yearly incidence in adults are up to 11%, but the real incidence of HMPV infection is difficult to measure or estimate. First, because a great part of HMPV infection is asymptomatic or mild, these patients do not present in the hospital. Secondly, the majority of the patients with respiratory symptoms presenting to our hospital are not tested for viral infections. Epidemiological study shows that elderly over 65 years, patients with cardiac or pulmonary disease and immunocompromised patients are at high risk for HMPV infection, presenting with severe disease than young adults without comorbidity. Now I can conclude HMPV is an important pathogen causing viral respiratory tract infection. People at risk are the elderly and the immunocompromised patient and patient with cardiac or pulmonary diseases. While HMPV infections are mild and self-limiting, the majority of adults clinically course can be complicated and these risk groups associated with morbidity mortality are considerable. The key issues of HMPV are is an important pathogen causing viral respiratory tract in adults, the elderly immunocompromised patient and patient with cardiac or pulmonary disease are at risk for severe infection. Distinguishing HMPV clinically from the respiratory virus, difficult diagnosis rely mainly on real-time body mass transcriptase PCR. Although a lot of research has been performed last years, treatment of HMPV infection is mainly suppurative and no vaccine is available up to till now. In case of severe infection, treatment with ribavirin and immunoglobulin IVIG might be considered. Here's some references.
Thank you very much, madam, for her excellent presentation, especially this hand washing video.
Honorable Chairperson, respected teachers and dear students, good morning. Before I say anything, I like to thank Professor Nasrin Sultana Chaudhary, madam, for your nice presentation and nice and elaborate presentation. Though perhaps I would say it in a different tone, because HMPV is prevalent in this planet or in this world for a long time. You have rightly mentioned last 50 years, some say around 100 years, but it has been identified in Netherlands in 2001 along with respiratory syncytial virus. Now, why we become so concerned nowadays? So I have some assumption. There is no study like that. First of all, there is a media hype. Out of nowhere, it has been started to say that this is a new virus, this is a different strain, this is a deadly condition. So after coming out of COVID, the whole world was very much apprehensive of this kind of conditions. So there was a media hype, and that fueled the panic button of the whole world. Number one is like that. Second is it has come from China. The news has come from China. That is another issue. If another thing is coming to the world. And there might be a third one also. All the population of the world is very much exhausted with COVID has just gone, and economic conditions are frustrating. The wars are taking place everywhere. So another bad news. So everybody has become very much concerned. Though it was never said by the scientific world that this is a new virus, this is a deadly virus, or this is a new strain. It was never said by the scientific world. But the message has been spread like that. And we have a disease we call in common terms common cold. Common cold. And nearly 200 virus, it is said that they are responsible, or the illness can be attributable to around 200 virus. And if we see that in most cases we don't even bother to diagnose. Say we don't have any easy tool to diagnose HMPV, and forget about around 200 virus. So these things are circulating in the world for a long time, and actually morbidity in most cases, you have said that it's so mild and sometimes asymptomatic that it doesn't cause any concern. But in some cases it might cause problem. Like in 2017, we talk much about COVID, but in 2017 there was a new strain of influenza virus in USA in 2017, and almost 77,000 people died in this condition. What happened to our country? Okay, we might have an outbreak, but we don't have the resource to identify each case of influenza and treat accordingly. And now, so among that, those 200 virus, one is HMPV. And so far the information we get, it's not exactly deadly. Okay, some people may become very much morbid and mortality might take place. But for COVID, it's like 0.24%. For HMPV influenza, it's like 0.0013%. So if 100,000 people infected for COVID, the death rate is around 24, but in HMPV case, it's much lower. Even it's much lower than the influenza also. And now there is another trend is found out that as this is seasonal, and it's coming along with the corona is still existing. So a quadruple infection has been also been seen. Like there is COVID infection, respiratory syncytial virus infection, influenza infection, and HMPV infection to same person. So this is actually common cold. Common cold. Now we become concerned. There are various reasons. Now what to do? What to do? So first of all, there is no vaccine. First of all, so that is out of our concern. And then you have said about ribavirin. It's in the list. In the list that it can be given, but this outcome is controversial. The result is not confirmed in a very large scale trial. Trial is also difficult because the patient are not that much symptomatic. Now the question is why China has become so abundant with this type of cases. There is another hypothesis for this, because we know COVID hit China in a severe manner, and at that time they have decided a zero COVID policy. For zero COVID policy, they have quarantine and other thing and lockdown, and they continued it for 2 years. They continued it for 2 years, and for 2 years they were kind of locked in their rooms, and that creates also a problem, because each year when we go to the environment, when we meet with other people, and we are actually infected by influenza, HMPV, RSV. As in 2 years they were isolated individually. In these 2 years they didn't get those infections. Infections are not always bad. Not always bad. It gives some protection also. We create our antibodies through infections, mild infections. And they opened up in 2023 and say there is an increased number of respiratory ARI, respiratory tract infection, whatever is the reason, in 2023 also, and also in 2024. Hopefully, as they are now getting exposed to the virus more regularly, perhaps it will come down. Then come the what to do. Ribavirin is an option, but it's not conclusive. Now the question is what not to do. What not to do. Frankly, in a situation like in a country like us, where a patient's coming with fever, cough, breathlessness, and if there is if chest X-ray shows there are patches or shadows in the lungs, it's very hard to resist to write any to omit it, not to give any antibiotic. It's very hard, and so antibiotic is given in most of the time. The problem is if we give antibiotic, these also, if it's not targeted and it's not doing any good, there is a chance that it will create some unfavorable conditions, because antibiotic kills the normal flora, which usually fights against the abnormal infectious agents. So that is a problem. So if we can do that, if we can wait for a few days, that might help. Antibiotic, to give antibiotic, there might be some logics that secondary infection might be prevented, but for HMPV there is no role actually, and there is no antiviral yet that is effective against and you have rightly mentioned the what should be done, like having good diet, exercise. Those are good for actually for any disease conditions. So, and actually this can be differentiated, bacterial and viral infections. It's for the students maybe. If a patient came with fever and cough, a simple few questions might be asked, like, is the cough productive or non-productive? If productive, then most likely bacterial. If non-productive, then most likely viral. And so a clinical scenario might also give us some clues. So now what to do? This is very important. Again, I like to thank Principal Sir for choosing these topics. This is a very important topics nowadays. For not because that this is a very deadly condition, but because we have to take care of this condition and we have to understand this condition, that this is not a very deadly condition. Okay, for some patients it might cause harm, like very young age, very old age, immunocompromised patients. So to understand these things, this CME is very much important. So at the end, just I want to say just one thing: should we be concerned? Of course we should be concerned. Should we panic? Absolutely not. Absolutely not. Thank you, everyone.
Now I am also requesting sir to take his seat on desk. Dr. Tariq Mohammed sir to take his seat on desk. Now I am requesting our presenter, Professor Dr. Nasrin Sultana ma'am, to take her seat on desk too. And then I am finally calling our chairperson, Professor Dr. Ghulam Rahman Dulal sir, Principal of Bosundhara Adli Medical College, to take his seat. Now the portion is for Q&A, that means question and answer session. If you have any question, you feel free to ask.
আমরা জানি যে আপার রেসপিরেটরি ট্র্যাক্ট বা পার্টলি লোয়ার রেসপিরেটরি ট্র্যাক্টে যদি কোনো ইনফেকশন হয়, মানে ভাইরাসিক ইনফেকশন করবে, তো ইনফেকশন করলে এটা কিভাবে, মানে মেকানিজমটা কি এটার দিকে নিয়ে যায়, আর এটা তো অনেক কিছু কোভিড-19 এর সাথে পুরোপুরি মিলে যায়, প্রিভেনশন থেকে শুরু করে সবকিছু, তো এটা কিভাবে মানে মৃত্যু পর্যন্ত নিয়ে যায় এটা পেশেন্টকে।
একটা ডিজিজের ন্যাচারাল হিস্ট্রি বলতে আমরা কি বুঝি? যে ডিজিজটা শরীরের মধ্যে ঢুকে নিজের মতন করে চলতে থাকবে, চলতে চলতে সে আইদার হইতে সে রিকভার করতে পারে, না করলে কি করবে সে ডিসএবিলিটি করবে, না করলে কি করবে সে ডেথ করবে। এগুলো একটা কিছু, এটা ন্যাচারাল হিস্ট্রি। আচ্ছা, এখন হতেছে তুমি জানতে চাইছো যে লক্ষণগুলো, সাইন সিমটমগুলো অলমোস্ট সেম, বাট বলেছি যে দু একটা জিনিস হতেছে কোভিডে হচ্ছে মারাত্মক। যেমন এখানে আমি বলেছি যে এখানে আমাদের কিন্তু যেমন কাফ যেগুলো আছে সেগুলো আমাদের তো থাকতেছে ওখানেই সেম, বাট ওখানে তোমার লস অফ অ্যাপিটাইটটা কিন্তু হয় না। কোভিডে কিন্তু আমরা যখন ডায়াগনোসিস করেছিলাম তখন কিন্তু লস অফ অ্যাপিটাইটটা দেখে কিন্তু আমরা বেশি কিন্তু ডায়াগনোস করতে পেরেছিলাম। আচ্ছা, তার সাথে আর কি কোশ্চেন ছিল আমি একটু ভুলে গেছি। মর্টালিটি, না HMPV মর্টালিটি একদম ওই যে স্যারও বললো, আমিও বললাম, আমি বিভিন্ন স্টাডি দেখালাম যে আমরা HMPV নিয়ে বেশ প্যানিক হচ্ছি। প্যানিক হওয়ার কিচ্ছু নাই, দিস আর দ্য পলিসি। হ্যাঁ, এটা হচ্ছে গ্লোবালি একটা পলিসি, প্যানিক হওয়ার কিছু নাই। কারণ এইটা আমি আজকে সকালেই জানলাম, এই ভাইরাসটা 300 বছর ধরে আমাদের মধ্যে আছে, এখনও আছে, 50 বছর ধরে তো চলতেছি। আমরা বললাম যে এই জিনিসগুলো আছে, সো প্যানিক হওয়ার কিছু নাই। এটা মানে আমি যে দেখালাম রেসপিরেটরি সিনসিটাল ভাইরাস এবং ইনফ্লুয়েঞ্জা ভাইরাস, এগুলোর যে পার্সেন্টেজ, এগুলো হতেছে পার্সেন্টেজ তোমার HMPV থেকে হাই। হ্যাঁ, HMPV কিন্তু লেস, সো এত প্যানিক হওয়ার কোনো কিছু নাই। দিস আর দ্য পলিসি গ্লোবালি। ওকে, থ্যাংক ইউ।
আমাদের কান্ট্রিতে একজন হচ্ছে শনাক্ত হয়েছিল, যেটা আমরা শুনতে পেয়েছিলাম, তো ওনার যে ডেথ হয়েছে ম্যাম বলেছিলেন, তো ওটার রিজন বা আমাদের দেশের প্রেক্ষাপটে ওর মানে পরিস্থিতিটা কি ছিল ওটা একটু জানার।
যেটা জানতে চেয়েছো যে আমি আমার স্লাইডে মেনশন করেছি যে মহিলাটা যে মারা গিয়েছিল, যে ওমেনটা মারা গিয়েছিল, তার কোনো কিন্তু ট্রাভেলিংয়ের হিস্ট্রি নাই, কোনো কিছু নাই, তারপরও HMPV শনাক্ত হয়েছিল এবং সে মারা গিয়েছিল। সে কেন মারা গিয়েছিল? তার হাজব্যান্ড হচ্ছে বাড়ি থেকে আসছিল, এবং তাছাড়া তার মধ্যে হতে পারে, এছাড়া ওই মহিলার সেপসিস ছিল, আদার কোমরবিডিটি ফ্যাক্টরগুলো ছিল, সে বিভিন্ন ধরনের অসুস্থতায় সে ভুগতেছিল। ঠিক আছে, সেগুলোর জন্য তারপর যখন সে প্রথমে একটা হসপিটালে গিয়েছিল, পরে মনে হয় IDH গিয়েছিল, তারপর ওখানে গিয়ে সে শনাক্ত হয় তার HMPV। ঠিক আছে, বাট HMPVর জন্য সে মারা যায় নাই, তার আদার্স ফ্যাক্টরসগুলো, হ্যাঁ, সেপসিস ছিল, হ্যাঁ, এগুলো ছিল, তার কারণে সে মারা গেছে। ঠিক আছে, আর আমরা তো একটা কথা বলেছি যে হাই রিস্ক গ্রুপ কারা, যাদের হতেছে কোমরবিডিটিগুলো আছে, কোমরবিডিটি কি, যাদের হাইপারটেনশন আছে, তারপর হচ্ছে ডায়াবেটিস আছে, কার্ডিয়াক কোনো প্রবলেম আছে, এগুলো যদি ইমিউন কম্প্রোমাইজড হয়ে থাকে, মহিলাটা এগুলো সব মহিলাটার মধ্যে ছিল, পেশেন্টের মধ্যে ছিল, এই জন্য সে মারা গেছে। বাট সে HMPVর জন্য মারা যায় নাই, এটা একটা ভুল ধারণা। ঠিক আছে, থ্যাংক ইউ।
I think I have a problem with the question itself. Why the patient died? It's not a right way to ask a question, because a patient has hypertension, a patient has say diabetes mellitus, patient having stroke, and there is HMPV virus, and there is also diarrhea maybe. So what is the cause of death is it's difficult. And if you go through your medical books, you will find that death and death related answers and questions are nowhere. We wish to say that this is CKD, this is AKI, this is the pathophysiology, we will treat the patient like this, it's 6.5, so we will dialyze the patient, there is electrolyte abnormalities, we will correct this way. But why the patient has died? It's a very difficult question. It's a very difficult question, because same infection happening to thousands of, hundreds of millions of people, and very small percentage has got severely infected. And those group, we know about those group. Those who are children, those who are very elderly and immunocompromised, whatever is the reason. So, and among them, there are some casualties. So, exactly speaking is very much difficult, very much difficult. And there is only one case has been notified. But the scenario is not like that. In a crowded country like ours, and if something spread by aerosols and droplets, it's virtually impossible to contain it to some places or some houses. It will spread. We are so populous. And there is another question: how can we differentiate between HMPV and COVID? Actually, clinically, it's, I have said that around 200 virus has been attributed to the same condition, common cold. In medical terms, we might call it acute respiratory infection. Whatever is the reason, it's clinically absolutely difficult. But there might be anosmia, but it could happen to any respiratory infection, but more in COVID, maybe more in COVID. There is another symptoms like happy hypoxia. I don't know whether you are familiar with the terms. Happy hypoxia is that in fact before COVID, even the doctors communities, scientific community even was not aware of this. That the saturation of the patient, and we are so stuck when we have initially faced this situation. Same patient having a oxygen saturation of 70%. In case of COPD, bronchial asthma, if it's around 90%, patient is severely breathless, dyspneic, and we become very much concerned. On the other hand, in COVID, the saturation comes down to 80%, 70%, 60%, 50% also, and 40%. And patient is complaining nothing. And now the question comes: why does this happen? The answer is that we don't know. We don't know why the COVID patient experiencing happy hypoxia. The oxygen saturation is low, but that producing no symptoms. And the terms is nice, happy hypoxia. Okay, thank you.
After diagnosing the symptoms, what will be the home treatment?
Sorry?
Home remedy.
Home treatment.
Home remedy. Home remedies, as been written in the slides, and in case of not only for this is actually should be followed for all cases of fever, and in case of especially viral fever. First thing is that adequate fluid intake, and it's so important. It's so important, and even if we follow the cases of dengue, which is very much endemic in our country, in our city, in fact, not in our country. So, in case of dengue, when the initial presentations happen, those patients who can take adequate hydration, adequate fluid and eat, actually they don't they suffer, they might go into the severe cases, but usually not, so adequate hydration for any viral infection is very much important. And there are other things like pathogen led diet, like yogurt. It has been said that yogurt is good because it will give some helpful flora to the body. Probiotic, it's kind of probiotic, so it's also good. There are studies, you are very much right. I have seen this, but this nut is good, that is good. There are some things, but if we follow a rule of thumbs, those things which are harmful supposed not to be taken, like lot of glucose water. This is absolutely bad for a normal situation, abnormal situation, or whatever is the situation. And glucose, lots of sugars, lots of fatty items, overburnt cooked item like fried chickens and those other things. Soft food, healthy foods, and plenty of fluids. I think that's some of the question. And the preventive measures that has to be taken. It has been shown very elaborately in the presentation.
Let's keep our promise and provide a chocolate to our student. And we are announcement that we are closing this Q&A session. Now I am requesting our chairperson, Professor Dr. Dulal sir, for his concluding speech.
Speakers, my senior teachers, junior teachers, and beloved students, Assalamu alaikum. Today we are learned many things from the new topics. I am suddenly selected these topics without to maintain our schedules of CME programs, because all of the country with these viruses are known to know. And few days ago that our newspapers say many things. It will be coming like COVID virus, but practically we are identifying with this time only one persons, and unfortunately this man is, or this woman is died. So we are all afraid, but these women have not only the virus infection is present, but incidentally this virus was identifying, and the female was also more than 65 years age and have several comorbid situation by this time, you know. So do not audit that this female is expert only to involvement these viruses. Basically she is died with the other comorbid situation. First we gives the thanks especially to the Professor Nasrin. He is nicely present here and have a new idea implemented into our slide deck, that how the hand wash is can be done. Basically it is previously identifying, now it is implemented in preventive medicine or others way, but in surgeon they are very early period this is uses, and this technique we are uses every times. And at the same time special thanks to Professor Tariq sir, because he is many things to inform us, not only in our hospitals, in our college or nationally, but he is informed many things all of the world at a glance in about the virus and practically what we do. So everyone need to get thanks from me and for proper time present here, and we are going to ending here also at the proper time. Thanks everyone, and inshallah we are going to be next session, that means next day again CME, that is 4th or 5th February, and maybe present from this man again from medicine, and we learn many things from again. Thank you all.